thank you so much for having me here. Merci beaucoup. This is the best French I have, so don't expect more. It's a pleasure to be among such a great audience. I am Batoul. I'm an Egyptian genetic counselor. And today we will be talking about endometrial recent studies and publications for clinical utility in the IVF domain. Before we jump in, I would just like to disclose that I am part of the Loai group, one of the labs that's offering the testing. So just a quick show of hands, how many have heard of endometrial test before? Okay, none. Okay, then I take it no one has used it in their clinical practice. So I have to use all my skills today. So back in up until the 1950s, the uterine cavity was thought to be a sterile cavity, and all the microbiome was thought to only inhabit the lower part of the female reproductive tract. Is that better now? Okay. Fast forward to our day today, we know now that 9% of the total human microbiome actually inhabits the female reproductive tract. And in opposition to what we thought before, the microbiome exists all along the female reproductive tract, not just in the lower part of the reproductive tract. And so we have also noticed that the biodiversity increases as we go up from the ovaries to the vagina, while the biomass decreases as we go up. So in other words, the vaginal microbiome is totally dominated by lactobacillus species, around 99.9%, while the endometrial microbiome has a higher biodiversity of microbial composition, still dominated by lactobacillus, but along other bacteria. Recent studies have showed that the endometrium plays a critical role in reproductive success. And when we think of endometrial health in the context of this presentation, we basically are thinking of two main parts, one being endometrial microbiome composition, and the other being endometrial health, endometrial receptivity. And this has led to the evolution of three main tests to look into those two components, namely Emma and Alice in one category and the other named ERA. And collectively, those make up the endometrium that I am here to discuss clinical utility in the IVF domain. And so one of the major studies by Moreno et al. In 2022, looking into the endometrial microbial composition and reproductive outcomes in around 300 patients, have found that actually the endometrium does have a microbial composition that is considered a huge factor in reproductive success. And it does recommend the endometrium microbiome to be studied before moving forward with IVF trials in order to come up with better and improve outcomes in reproductive success. In particular, in patients with poor reproductive outcomes, it was seen that those patients have higher chances of having a pathogenic profile, or what we call a dysbiotic profile, and that just means that they don't have a lactobacillus dominated endometrial microbiome, but rather dominated by other pathogenic bacteria. In contrast, patients with better or good reproductive outcomes and live birth outcomes were seen to have an overall lactobacillus dominated microenvironment, or else an absence of bacteria, which we call the ultra-low biomass. And this, if anything, hints towards the role of lactobacillus in avoiding colonization of the endometrium by other pathogenic bacteria that might be hindering reproductive success. And this is basically where Emma and Alice come into play. So Emma is standing for endometrial microbiome metagenomic analysis. And this is basically a molecular assay that helps to look into the microbial composition of the endometrium, allowing us to assess the presence of both lactobacillus as being the most useful bacteria in the human microbiome in the endometrium, as well as other bacterial pathogens pathogens, including those associated with chronic endometritis. And this is just a list of the bacteria. This is a very low quality picture, but this is just a list of the bacteria that are usually looked at. It's not a comprehensive list. It can differ between the labs that are offered the testing, but this is just for reference. On the other hand, as the name implies, ALICE is mainly targeted towards the analysis of the bacteria involved in or associated with chronic endometritis. And as most of us know, chronic endometritis is an infection or an inflammation of the endometrial lining that is basically caused by, in most cases, bacterial infection. And because it's usually asymptomatic and the typical diagnostic methods, including hysteroscopy and histology, are usually not very satisfactory, then most of the cases of CE might go overlooked or underdiagnosed. But this is not to undermine its contribution to the infertility population. So chronic endometritis is known to be present in around 30% of the IVF population, and it goes up to a prevalence of up to 60% in people with recurrent implantation failure or recurrent pregnancy losses. And so, if anything, that's just pointing towards the huge role it plays in the IVF domain, and that's something not to be overlooked. And so with this in mind, Emma and Alice have grown to be of clinical utility in the IVF domain, particularly for patients with recurrent pregnancy losses or recurrent implantation failure and infertility. And really, it's recommended for this population, but it can be considered to anyone who's wishing to conceive. By assessing the endometrial microbial composition, we're able to tailor an individualized treatment, whether it be antibiotics or probiotics, in order to improve the clinical outcomes, including implantation success or live birth outcomes. This, of course, was supported by multiple studies. Two of the major studies were led by Emawe et al. In 2023 and another in 2025. The first one in 2023 looked into a population of recurrent implantation failure patients, while the one in 2025 included a bigger study group of both recurrent implantation failure patients as well as recurrent pregnancy losses. Overall, around 20 to 25% of the study group was seen to have a dysbiotic or a pathogenic profile, which required an antimicrobial therapy. Additionally, in the 2025 study, it was seen that 1 in 3 patients required a probiotic treatment as well, meaning that the lactobacillus composition was lower than what we would expect. And so all in all, live birth rates were seen to be higher in the groups that utilized treatment, whether it be antibiotic or probiotic, as guided by the Emma and Alice results. For example, in the 2023 study, it was seen that compared to the control group who never utilized Emma testing, the live birth rates were around 9.6%. But when considering the group that utilized Emma testing and subsequent treatment based on the results, the live birth rates were up to 33%. Which again calls for the clinical utility of such testing in the IVF domain. Additionally, pregnancy was seen to be achieved 6 months earlier in the group that received antibiotics and probiotics as guided by the Emma and Alice results. So again, showing that addressing the uterine dysbiosis might actually reduce the time to clinical pregnancy and improve reproductive outcomes. Well, then comes the inevitable question. Why should we move away from the classical diagnostic ways for CE or for the endometrial composition? We all know change is tough and change is costly. So based on the studies, it has been shown that hysteroscopy and histology, both of which are the classical diagnostic ways for chronic endometritis, can be subjective and they might be misleading or inconclusive in up to 80% of the cases in some studies. And so they might not be the most the most accurate representation of what's actually in the endometrium. As for the culture that's used to assess the endometrial pathogens, it was found that around 20 to 60% of the human microbial flora are non-culturable, which just means that we stand a risk of false negatives because of the inability to culture those microbial pathogens that might actually be contributing to the poor reproductive outcomes. And so collectively, those molecular analyses, including both Emma and Alice, can provide a way to an alternative to overcome those limitations and provide a more objective approach of analyzing the endometrial microbial composition. And so back to this study, back to this diagram, we discussed Emma and Alice and how they can be of great utility in the clinical domain. Coming to the ERA testing, according to the studies, it was shown that in addition to a euploid good quality embryo in a lactobacillus-dominated microenvironment, the synchronization between the embryo implantation and the receptivity of the endometrium is a huge part and a huge component of reproductive success. And this is basically where the ERA, the endometrial receptivity analysis, comes into play. But a little background on recurrent implantation failure. It's known to account for around 10% of the IVF population, and per the ASHRAE good recommendations in 2023, endometrial receptivity was among the factors that can be considered as hindering or limiting to the reproductive success in terms of implantation. And so among the recommendations, in addition to the Emma and Alice, ERA was also noted to potentially be considered as a way to improve reproductive outcomes. And so back to the ERA, introduced back in 2011, it was the world's first molecular assay to allow for an individualized implantation window, so assessing each woman's unique personalized embryo transfer timing. So according, as we can see in this diagram, the window of implantation is basically a short period of time between 3 to 6 days. In some people, in some women, it can be as short as 24 hours. It lies within the secretory phase of the menstrual cycle, and this is basically where the endometrium is most receptive to blastocyst implantation. And so you can imagine having a displaced window of implantation might mean that that standard timing of implantation is reached a bit later or earlier than it usually is. And so transferring an embryo into a woman with a displaced window of implantation within the standard timing might mean higher chances of implantation just because it was not transferred in the right moment. And so this is where ERA basically comes into play. It is mainly indicative for patients with recurrent implantation failure, and as backed up by a huge study, a randomized controlled study, it was seen that in patients between 35 to 45 years of age who received both PGTA and ERA testing, the pregnancy rates were higher compared to the control groups, either those who did not receive the ERA testing or those who were younger than 35 years of age. Similarly, implantation rates and live birth rates were seen to be higher in those populations, which, if anything, is calling for the clinical utility of such test in the RAF population. One thing to note is that in the previous RCT study, women of older age were seen to have a higher likelihood of having a displaced window of implantation, particularly having late receptivity, which again calls for the use of ERA in those populations. Another huge consideration is that one of the main studies that was arguing against the clinical utility of ERA in this population, basically showing no difference between those who used ERA and those who did not, was actually recently retracted from the literature because of insufficient evidence and triplicated evidence. And so this again might be a hint towards the use of ERA in the IVF domain. And in addition to the RAF population, where ERA has demonstrated much clinical utility and is growing to be more of a component in the investigation, ERA is also, some studies have supported its use in other clinical indications, including patients with obesity or those with an atrophic endometrial lining, those with adenomyosis, and those with biochemical pregnancy losses, all of which we're seen to have a potentially displaced window of implant, higher likelihood of having a displaced window of implantation. So again, ERA might help personalize and individualize embryo transfer based on each woman's unique embryo timing. And so I have taken 15 minutes to talk about why you should use Emma, ERA, and Alice. So realistically speaking, each test has its own limitations, and so it is crucial to highlight those limitations too. Those tests are specific. They deliver what they promise, nothing less, nothing more. And so Emma and Alice are not going to be looking at every single bacterial pathogen in the endometrial microbiome. It's very specific. It looks at the most commonly reported bacterial pathogens. The panels can differ in size, but around 300 bacterial species could be included in this test, whereas ERA does not report on the endometrial pathology, nor does it predict the health of the pregnancy. With the use of those tests, yes, we do increase the likelihood of positive pregnancy outcomes, but it's not a guarantee of pregnancy. Many factors come into play when thinking of reproductive success. Other factors might include the embryo quality, genetic makeup, other pathologies. And so this is just a step closer to positive reproductive outcomes. It's not the magic solution. Emma and Alice are not for sexually transmitted diseases, and so this is not what they should be used for. And in around less than 5% of the cases, can be as low as 3% or even lower, we might request a rebiopsy because the first endometrial biopsy was basically having insufficient quantity or quality that is not allowing us to make a conclusive diagnosis. And so in those cases, we request a rebiopsy in order to improve the chances of having a confirmative diagnosis. With this, I conclude my study. And so just to wrap up, the endometrial microbiome does have a role in infertility, and this dysbiosis was reported with poor reproductive outcomes in IVF patients. Emma can provide a way to analyze the endometrial microbial composition, in addition to Alice, specifically for chronic endometritis bacterial pathogens. And compared to the classical diagnostic methods, those molecular techniques can overcome the limitations that were discussed by the three classical ways, allowing for a more objective analysis. The use of Emma and Alice has indeed shown improved IVF outcomes in patients with recurrent pregnancy losses, or recurrent implantation failure. This outcome was measured in terms of higher pregnancy or live birth rates, shorter times to pregnancy, and so on. The synchronization between a good quality embryo, a good endometrial microbial composition, and endometrial receptivity does increase the chances of success in ART patients. ERA is the world's first backed up test by RCT that's commercially available to allow for analyzing the receptivity of the endometrium. And finally, ERA has demonstrated significantly better outcomes for patients who have used it in addition to PGTA compared to those who did not use it or those of lower age groups. And so again, it has also seen promising outcomes in advanced maternal age patients. So this concludes my study. I am sorry it was not as interesting as Dr. Shawky's, but I tried my best. Thank you so much, and I am happy to take questions if we do have time.
Thank you very much. We will have time for 3 to 4 questions. Okay. Yes, Samir.
Yes. Thank you, Karin. Thank you, Madam, for your
Thank
talk.
you.
My question just only for ERA test.
Mm-hmm.
I advise you to read the excellent paper which published in JAMA journal 150 impact factor. About ERA, the conclusion is there is no benefit of ERA test even in repeated implantation failure. That's the first one. Second paper from Iverma from Valencia, published in Fertility and Sterility by the group of EV, to mention again, there is no any benefit of ERA test. I'm surprised today we speak again about ERA test. Thank you.
If I may just get to that, I'm sorry. I definitely agree with you. There have been several studies that talk about the clinical inutility of ERA in this domain, but most of these studies were seen to not be including the right group of patients. I am happy to talk more about that when we go down. Yeah.
Thank you for your interesting lecture. I won't talk about ERA test because I have my own opinion.
Yeah.
Which I will keep. But I will talk about chronic endometritis, which is a very interesting topic, and you talk about microbiome. My concern is certainly the cutoff of the normal microbiome when we use NGS. That's why ESHRE recommended not to do evaluation of microbiome and to go directly to immunohistochemistry with 138 antibodies, and certainly adding the acuity when we use also the MUM1. So I think there is some message to keep or to take home a message. Maybe microbiome using NGS can be interesting, but I think that for chronic endometritis, a hysteroscopy and evaluation of CD138 and MUM1 should be the gold standard for as a diagnostic criteria for chronic endometritis.
Definitely, there is no one right answer. It's a combination of factors that need to be taken and considered, and that's why the ESHRE recommendations does not point towards one specific diagnostic method. It's just an extra step to make sure that we're providing an objective look of the endometrial composition.
Last question, please.
No question. Just some comments and your comments about my comments.
Yeah.
Chronic endometritis, really real problem. We're still in the fog. We're still in the fog. When you do assessments by hysteroscopy, you can see you can see micropolyps or inflammation, but it could be related to hormonal imbalance. It could be related to autoimmune pathology. It could be related to microbes. Right. And when you do sampling, you don't find the pathogens. You find it only, I think, 1 or 2 patients or less. So we're still in the problem. And in the study presented by, I think, Carlos Simon with the ribosomal RNA to be more accurate in the diagnosis. At the end, you see in the treatment group, at the end, they give probiotics, vaginal probiotics after treating. So it could be something that could change the results because both groups received probiotics. So chronic endometritis is still not enough accurate to make it in the making decision process.
Yes, sure, and that's why I mentioned that it might be caused by the endometrial microbiome disbalance, but this is not the only cause. There are multiple causes, but if we're talking about the endometrial microbiome associated causes of CE, then Emma and Alice have been showing good results.
Thank you very much, Dr. Batoul.
Shukran.
You're most welcome in Morocco.
Thank you.